Good afternoon, folks. Many thanks to Ellie and to Derek Thomas for inviting me to present here today. I'm going to be presenting to you from a clinician's viewpoint, as I'm also the lead Tissue Viability Nurse for the Velindre Cancer Centre in South Wales. So that's the angle I'll be coming to from today. So I was asked to talk about the role and pressures of nursing in wound care. So if I start with talking about what my role is. So wound care covers a very broad spectrum of individuals from premature babies to people at the end of their life. So we have to have a very broad perspective when we're caring for patients with wounds. The majority of wound care is delivered by district nurses and community nurses in the community or in GP surgeries or in the patient's own home. So what do I do? Well, I assess and manage all types of lower leg wounds. The majority are venous ulcers, which for those of you that don't know what a venous ulcer looks like, you can actually lose all the skin on your lower leg. It can be excruciatingly painful. It constantly can leak fluid onto your clothing, your bedclothes, your furniture. It can produce a foul odour and smell, which is terrible, especially on a hot day. It can often become infected for no particular reason. And these cycles of infection and infection being cleared carry on and on for people. And the leg ulcers themselves are managed with wound dressings and compression bandages. So the initial assessment of a patient with a lower limb wound will take about an hour. And I'm lucky that I have that time to do that. Not many nurses do. A practice nurse who works in a GP surgery has 10 minutes. Part of the assessment is we assess the person's circulation, which has been alluded to this morning. And what we have to do, we have to put a blood pressure cuff that normally goes around your arm, around your ankle, which is quite often where the ulcer is. And then we have to inflate the cuff. So you can imagine how painful that is for people with lower leg wounds, and that's part of a formal nursing assessment. When we've done that, we will make a care plan. And the care plan will say what we want to happen to that patient's wound. And the care plan is made in collaboration with the patient. Because what we plan might not fit in with their lives. It might not be meeting their priorities. So it's not what the healthcare professional wants, it's what the patient wants, and we work together to get a sound plan of care. That plan of care then will go to the community nurse for them to implement. The wounds are reassessed on a regular basis. When they're at their worst, it can be daily, twice weekly or monthly once things start to heal. And when we're assessing those wounds, we're looking for signs of deterioration or improvement. Because a lot of people think a wound starts here, we treat it and it goes here. That's not the case in real life. It's like a roller coaster of healing, deteriorating, healing and deteriorating. We also, when we're assessing a person's lower leg, we don't just look at the leg that's got the problem, we look at the other leg too. Because as was alluded to earlier, we need to prevent. So we need to keep the good leg in good order. But prevention is not a priority within the NHS. If and when the ulcer heals, which may take many months or years, and we've people on our books who have still had leg ulcers after 20 years, a long, long time to live with a wound. And if the underlying problem has not been fixed, the individual is going to have to wear compression hosiery, which is akin to flight socks, for life, because we haven't dealt with the problem. Unless they're lucky enough to live in an area where we can get surgical intervention to prevent recurrence, but this is a postcode lottery that we've heard mentioned already. And even if they do concord and wear the bandages, wear the hosiery, as I said earlier, the chances are it's going to recur. And that must be a very, very terrible place to be, that no matter what you do, it's going to come back and your same problems will be there again. So that's what we do in our role as nurses. But what are the pressures? As was said earlier, 70% of leg ulcers are venous, but 30% aren't. But if you look to see who manages these leg ulcers, the majority are nurses. We are not taught to diagnose. Our medical colleagues are taught to diagnose. But how many of us as nurses have got a medical colleague who has got any interest, knowledge and skills in the area? Not many. I've been lucky enough to work alongside Professor Harding and have been taught by him and seen him in action diagnosing these unusual types of wounds. Rob Bowden, a GP, a very well-informed GP, but that is not always the case when it comes to wound care. So as a nurse, you might turn to a doctor for support, but you probably won't have one there. And we've all heard about the team approach this morning. Well, the team approach can't occur if you haven't a team to start with. And that's a pressure for many of us as nurses. We need that team. If we haven't got the medical input, the patient can wait a long time for a diagnosis. And as Keith will say, if we have no diagnosis, we can't put in a plan of care. We've got to have that accurate diagnosis, and that has to be made by a medic. If we don't have that input, and we suspect a patient has a cancer in their leg ulcer, they can be waiting many months to get a biopsy before we can treat that. So this lack of medical support is crucial. And it can, as people have said earlier, result in an individual receiving incorrect treatment and having a never healing wound. And we'll hear more about this later from Anne and Anna. Another pressure I find is this myth amongst nurses. And this myth is that the dressing heals the wound. And when the person isn't healing, it's the fault of the dressing. So what will the nurse do? Change the dressing. What they need to do is to get to the source of what is causing the problem. If the patient isn't healing, the problem lies with the patient, and that should be assessed. But that doesn't always happen. We have this ridiculous situation of chopping and changing dressings, which gets the patient no further forward, especially if that's on top of an inadequate diagnosis. Some of the treatments we have, many of our industry partners here today, provide marvellous interventions for our patients that really help us to manage their symptoms and move them towards healing. Since COVID, we have had a lot of self-management that has been imposed on patients. And do they have the ability to manage? Do they have the knowledge to manage? Do they have the manual dexterity to even apply the things that we've provided for them? Not always. So self-management is there. For some patients it works well, but for some patients it's not suitable at all. But they're left with their dressings, their bandages, and they have to get on with it. And that's a frustration for me, because we haven't assessed who's capable of self-caring and giving them the right support they need to self-care safely and effectively. There are tissue viability nurses like myself who can support the community nurses in assessing and managing wounds. However, as a tissue viability nurse in the UK, there is no set job description. There's no set medical educational requirements. You can be a ward nurse one day and a tissue viability nurse the other day. How can that be safe and effective for our patients? Each health organisation may have a single tissue viability nurse, they might have a team of tissue viability nurses, or they might not even have one at all. Again, a postcode lottery. But what I am certain is there are too few tissue viability nurses to give the support that the general nurses require in the clinical areas. Again, I have two colleagues here, Helen Dawkins and Wendy Simmons, who are lead tissue viability nurses in South Wales with me. And if you'd like to know more about the frustrations that we feel in our role, please talk to Helen and Wendy at the end of the session. As Keith has said, we need to measure outcomes. And as Keith has always said as well, success in wound healing is often based on how many patients a nurse sees in the day. That is not the answer. Success should be around patient-reported outcome measures and patient experience outcome measures. And finally, there is a lack of leg clubs throughout the UK. I am passionate about leg clubs. They give excellent care in a happy, fun, warm and caring environment. And they are the way forward. So for any MPs here, please, if you haven't got a leg club, let's have one. And if you have got one, please go and visit. Thank you.